So here we're going to discuss the respiratory tract infections. And the respiratory tract has an upper respiratory tract and lower respiratory tract. In the upper, you have your nasal cavity, pharynx, and larynx, and the lower, trachea, bronchi, and bronchioles. In this lecture, we're only going to focus on the upper respiratory tract. So we have factors, the host has factors that give us protection from respiratory infections. So non-specific protection that we have are the hairs in our nasal passages, the fact that our nasal passages especially, are very convoluted. We have mucous membranes in our upper respiratory tract. We have secretory IgA and lysozyme production. There's also cilia lining the upper respiratory tract that can trap any microbes. And we have reflexes such as coughing, sneezing, and swallowing, which help us get rid of some microbes that may get into the upper respiratory tract. We also have our normal flora, our upper respiratory tract normal organisms. So our normal flora of the naso and oropharynx. So just like throughout our entire body, we need our normal flora. Our normal flora is there so that it has functions, and one of the functions is that it suppresses the growth of pathogens that might get into that area. So the possible pathogens in the naso and oropharyngeal passageway. We have Acinetobacter, Streptococci species, Staphylococcus aureus, Neisseria meningitidis, Mycoplasma, Haemophilus, Moraxella catarrhalis, the yeast Candida albicans, herpes simplex virus, our Enterobacteriaceae family members, various mycobacterium species, Pseudomonas, especially Pseudomonas aeruginosa, some of our fungi, Eichinella our anaerobes such as Bacteroides, Peptostreptococcus, and Actinomyces. Rare pathogens. So these organisms you can isolate from the naso and oropharyngeal cavity, but not as often. So this would be your non-hemolytic strep, your staphylococci, your micrococci, your corynebacterium species, your coagulase negative staph, other Neisseria species than meningitidis, lactobacillus, campylobacter, and Veillonella. So the pathogenesis of our bacteria that may infect our upper respiratory tract. These organisms usually have adherence factors such as adhesins and fimbriae. They may produce toxins. They have the ability to grow, some of them within cells. They have the ability to evade the host's immune responses. Some of them produce capsules which allow them to not be phagocytosed, so our capsule organisms, Strep pneumoniae, Neisseria meningitidis, Haemophilus influenzae, Klebsiella pneumoniae, and our encapsulated Pseudomonas aeruginosa strains. The organisms that can multiply within host cells, which also allows them to evade the immune response, we have Chlamydia, Legionella, and Mycobacterium tuberculosis. So our definite respiratory pathogens, if you isolate one of these organisms, it is most likely causing a problem. So we have Corynebacterium diphtheriae, we have Mycobacterium tuberculosis, Mycoplasma pneumoniae, Chlamydia trachomatis and Chlamydophila pneumoniae, Bordetella pertussis, Legionella species, Nocardia species. Then we have our yeast, Cryptococcus neoformans, and our various viruses. Rare respiratory pathogens, now these are respiratory pathogens, but they're not isolated very often, thankfully, because these are very dangerous organisms. We have Francisella tularensis, Bacillus anthracis, Yersinia pestis, Coxiella burnetii, Brucella species. All of these are bioterror agents. Then we have our Pasteurella multacida and our Chlamydia psittaci. If you guys remember, Chlamydia psittaci is associated with psittacine birds such as parrots. Okay, so upper respiratory tract. The diseases of the upper respiratory tract, we have laryngitis, laryngotracheobronchitis, epiglottitis, pharyngitis, tonsillitis, rhinitis, and stomatitis. So laryngitis usually is something that comes along with a common cold or maybe the flu. Symptoms are hoarseness, having a difficulty speaking. Acute laryngitis usually is due to a viral infection. It's benign. It can be due to influenza virus, rhinovirus, or adenovirus. Laryngitis that also has an exudate, so you're coughing up things, or a membrane, like a pseudomembrane. Pseudomembrane, you always have to think Clostridium Corynebacterium diphtheriae, which is the cause of diphtheria. Mononucleosis, which is caused by a virus, and streptococcus. Laryngotracheobronchitis, this is also called croup. This is more common in children under 3 years of age, and the symptoms include possibly a fever, difficulty moving air through the larynx, so maybe a wheezing, difficulty breathing, hoarseness, and a barking, non-productive cough. And by non-productive, meaning coughing but not bringing up any mucus with that cough. This can be associated with severe respiratory distress as well as fever. So usually this is due to viral infections such as parainfluenza, influenza, respiratory syncytial virus, and adenovirus. Epiglottitis is an infection of the epiglottis and the soft tissue above the vocal cords. It usually is associated with fluid and swelling, very common in children between 2 and 6 years of age, and the symptoms include fever, difficulty swallowing, drooling, and possibly respiratory obstruction. Usually epiglottitis is caused by bacteria, especially Haemophilus influenza type B, Streptococci species, and Staphylococci species. So culture for epiglottitis is contraindicated. So if someone has an infection in the epiglottis, you usually don't want to swab that area. That could actually spread the infection and cause respiratory obstruction. So diagnosis of epiglottitis is made by clinical symptoms, and usually it is a bacteria if it's found in children, and a broad spectrum antibiotic would be used to treat the epiglottitis. Pharyngitis and tonsillitis, usually this will be associated with pharyngeal pain, with an inflammatory exudate, possibly vesicles in the back of the throat, little pus pockets, ulceration of the mucosal epithelial cells, and swollen lymph nodes. It's much more common in the colder months, so in winter, usually accompanied by other infections. So you may have a combination of a viral infection as well as a bacterial infection. So for viruses, you have influenza A or B, adenovirus, parainfluenza virus, Coxsackie A, rhinovirus, and coronavirus. For bacteria that causes pharyngitis, the most common organism is Streptococcus pyogenes. Peritonsillar abscess. This is usually a complication resulting from tonsillitis and is more common in children and young adults. It can spread into adjacent tissues, and the common agents are your non-spore forming anaerobes such as Fusobacterium, Bacteroides, and your anaerobic cocci. Also, it can be caused by Streptococcus pyogenes and your viridans streptococci. Rhinitis is inflammation of the nasal mucosa. The symptoms usually you may or may not have a fever, increased mucus secretion, inflammation, fluid in the nasal mucosa, sneezing, watery eyes. Usually rhinitis is caused by a virus, respiratory virus. So for specimen collection of the upper respiratory tract, it usually is a swab, either a cotton or a Dacron swab. Swabs should remain moist and they should be cultured within 4 hours. If they are not going to be in the lab and cultured within 4 hours, the specimen has to be put into transport medium. So if group A streptococci is suspected, this organism is highly resistant to desiccation or drying out, so it really should put into transport medium to keep it moist. Specimens for Bordetella pertussis. These are usually aspirated nasopharyngeal secretions. The best specimen is a cough plate, so directly cough right onto a plate, or if it is a specimen, to inoculate it right at the patient bedside. Transport to get to the lab and to start culturing should be no more than 2 hours for Bordetella pertussis. And remember, Bordetella pertussis causes whooping cough. So 1% casamino acid medium can be used, charcoal horse blood transport medium, or 5% serum inositol in fetal bovine serum. So remember, Bordetella is a fastidious organism. It doesn't grow well on a lot of just your typical media, so you need a special transport media to keep this organism viable in order to culture it. So for a direct examination of the upper respiratory tract, that is not useful, unlike the lower respiratory tract where you want to do a direct examination to see the quality of the specimen. Upper respiratory tract, you're going to see a ton of organisms, all different kinds of organisms. Keep in mind all the normal flora of the mouth. You have your anaerobes like Bacteroides, Prevotella, Porphyromonas. You could have Fusobacterium, Lactobacillus. You have a ton of alpha hemolytic streptococci, your viridin strep. You can have Eikenella carodans, diphtheroids. There are so many organisms in the mouth that an upper respiratory tract direct exam is just going to show you a ton of organisms, and you're not going to be able to tell what might be a pathogen and what isn't. If you did have a direct specimen, you can do fluorescent antibody staining where you have an antibody against a very specific organism. So if you get fluorescence, then that means that organism. Culture is going to be the most common thing to do for an upper respiratory tract specimen as opposed to a direct examination. And what you'd be looking for in an upper respiratory tract specimen most commonly is going to be Streptococcus pyogenes. You also might look for Corynebacterium diphtheriae, Bordetella pertussis, Neisseria species, and all of these organisms can be associated with epiglottitis, but remember, for epiglottitis, you really don't want to do culture. You're not going to stick a swab in because you don't want to spread certain organisms in that region. So for epiglottitis, you wouldn't do culture. It would just be diagnosed based on symptoms. Okay, strep pyogenes is the primary cause of bacterial pharyngitis. This is the most commonly routinely screened organism from a throat culture, so a throat swab. You're always going to inoculate it onto 5% sheep blood because you want to look for that nice beta hemolysis. If you're culturing for strep pyogenes, you're going to drop a 0.04 unit bacitracin disc onto the plate. And if the organism is susceptible to that disc, if you get a zone of inhibition, then that would indicate strep pyogenes. You can do direct antigen tests, agglutination reaction types of tests from your specimen. If you get agglutination, that means that strep pyogenes is there. So that would be a more rapid test, so you don't have to wait overnight for culture. And you can do PYR testing on suspected colonies. For Corynebacterium diphtheriae, you're only really going to look for this organism if it's specifically requested. So in addition to your blood agar plate that you're always going to use for an upper respiratory sample, then you'd have to add in special media for Corynebacterium like Loeffler's agar or cysteine tellurite agar. For Bordetella pertussis, again, this is best sampled directly onto media at the bedside or using a cough plate. So positive isolates are going to vary between 20 and 98%. And again, you would need to inoculate very special media, Bordet Genjou, Regan Low, or chocolate horse blood agar. For Neisseria, usually you're going to suspect Neisseria meningitidis or Neisseria gonorrhea from an upper respiratory tract specimen. So if Neisseria were suspected, if it's Neisseria meningitidis, it would grow up on blood agar. But remember, Neisseria gonorrhea won't grow on blood agar. So you'd have to use your selective media, such as modified Thayer-Martin agar, Martin-Lewis agar, New York City agar, and you'd want to put it in CO2 to allow your Neisseria to grow. So upper respiratory tract specimens are normally put in CO2 because the most common thing you're looking for is Streptococcus pyogenes, which grows best in CO2. So for, again, Neisseria meningitidis, you would get it to grow on blood agar, but Neisseria gonorrhea, you would need chocolate agar, and it's better to use your selective media so that you don't get an overgrowth of normal flora. So epiglottitis, again, you don't usually culture for it. If you did culture for, if you had a swab that was from an epiglottitis, you would plate it onto blood and chocolate. You want to add that chocolate agar because you'd want to look for Haemophilus. You would also record the presence of Staph aureus, strep pneumoniae, or any beta hemolytic streptococci. You can do non-culture testing such as latex agglutination, ELISA types of tests, and gene probes. So here's a case. You have a 5-year-old male. The day before he was evaluated, he woke up with a sore throat and a fever. He was given Tylenol. He woke up the next day with a sore throat and fever, as well as a headache and abdominal pain. Only the child was ill, so the parents were not ill. On physical exam, the child had a fever. He had very red back of his throat, tonsillar region, and the soft palate. He had enlarged and tender cervical lymph nodes. He did not have a rash. He didn't have any lesions on his skin. So points to consider for this case: based on the age of the patient, the symptoms of this patient, what is the most likely organism that you'd want to be looking for? And why would it be important to determine what's causing this infection? And what tests would you do to see if this patient has that infection? So these are the things you always want to be thinking of. What might it be? So this is the patient's throat culture. So a throat swab was taken, streaked out for isolation. In the first quadrant, a bacitracin disc was placed. There is a zone of inhibition, and you see nice beta hemolytic pinpoint colonies. So automatically, you should know what this organism is. Here's a gram stain of one of the colonies growing up on that plate. You can see nice gram-positive cocci. So hopefully you know exactly what that organism is. Any of the organisms that we talked about in this lecture, we talked extensively about all of those bacteria last semester. So if you don't remember anything about some of those organisms, you want to either go to your textbook or go back to the notes from last semester and review those. Review what those organisms are and the key tests that you would need to do to differentiate them.